So welcome everybody. Good afternoon, good evening, good morning. Welcome to the first IOA Network call of 2023. We have a very personally passionate, all of us very passionate in the IOA team topic looking at gendered roles and sex-related differences in outbreak dynamics and response interventions. We have 3 presentations today. So we have the case for collecting, analyzing, and utilizing sex-disaggregated and gendered data to inform outbreak response from Emelie Yonally Phillips in Epicentre. Looking at monkeypox infection in pregnancy from Asma Khalil in St. George's Hospital. Looking at access and engagement with public health interventions in Nigeria, a gendered lens and its implication from Chukwuebuka Ugwu and the Liverpool School of Tropical Medicine. So we've got a full house. So I just want to check that Emelie is with us.
All right, so to get started, welcome everyone. I'll be talking to you today about the case for collecting, analyzing, and utilizing sex-disaggregated data and gendered data to inform outbreak response. So this is a systematic lit review, and it's the first phase of the larger SAGER IOA guidelines project. This is a multi-agency project being guided by an advisory group of amazing key partners. And the project emerged from the growing recognition in the literature and the field that the inclusion of sex-disaggregated data and gender data in outbreak analytics really helps us to understand who and how individuals and communities are affected. And it's really critical to stopping transmission and delivering an effective response. So in recognition of this, recommendations and minimum requirement guidelines have been developed. One of these is the Sex and Gender Equity in Research, or SAGER guidelines, supported by Gendro, that were published in 2016. However, despite the available guidance, there remain significant gaps in the availability of these data, particularly during outbreak and public health emergencies. So in 2021, the GORN Analytics for Outbreaks Working Group identified the need to adopt the SAGER guidelines for operational integrated outbreak analytics. And for this project, we're taking a multi-phase participatory approach. Phase 1 is a systematic literature review that's currently underway and will be the subject of this presentation. Phase 2 aims to be a truly participatory process of consultation and workshop with actors working in specific outbreak and public health emergency responses to really co-create concrete, practical mechanisms for systematically integrating sex and gender data in the local context. Phase 3 will then be drafting of the adapted SAGER IOA guidelines using the concrete examples that were co-developed in Phase 2. And Phase 4 will be a piloting and revision of the guidelines. So to start with Phase 1, for this systematic lit review, we had 3 main objectives. The first, to understand the implications of integrating sex-disaggregated data and gendered data in these responses. 2, to understand outbreak dynamics and considerations for preparing more appropriate and really gender transformative responses. And 3, to describe the current gaps. So we searched 5 databases for peer-reviewed literature examining sex and gender specific outcomes for communicable disease outbreaks using IHR, FIIC, and SPHERE standards to define outbreak diseases. COVID and TB were excluded due to the extensive gender research already being conducted on these diseases. Our search produced 15,601 articles to screen, 71 of which met inclusion criteria and were included in our analysis. The majority of these looked at Zika and Ebola. So one of the first things we noticed looking through the literature is that many of the articles we reviewed, and just in general, we often use the terms sex and gender interchangeably, which is not only incorrect, but can obscure the actual ways in which sex and gender impact disease and public health emergencies. So just to start with a few quick definitions, Sex refers to biological characteristics, including the basic organization of chromosomes, reproductive organs, and circulating sex steroid hormone concentrations. It's the combination of these sex characteristics in each individual that determine if they're labeled intersex, female, or male. And it's really important to note that the term intersex is kind of a catch-all other term that covers a number of different sex categorized characteristic combinations that are not included in the normalized binary female-male categories. And these may have different impacts on disease dynamics, because sex results in physiological differences that contribute to differences in our ability to control and clear pathogens, as well as anatomical differences that may affect exposure and transmission pathways. Gender is really a set of socially constructed roles, behaviors, activities, and relations that a given society considers appropriate for women, men, and non-binary individuals. And these include gender norms associated with education, occupation, and health-seeking behaviors, and likely associated with behaviors that influence differential exposures to pathogens and differential access to prevention and treatment options. It's also important to note that gender interacts with biological factors in ways that can impact outbreak dynamics, such as gendered activities that shape risk of prior or related disease exposure, resulting in comorbidities, gender relations that shape nutrition status, etc. And both biology and socially constructed gender roles change over a person's life course. So age is a really important factor to look at the impacts of both sex and gender-related outbreaks and dynamics. So for our analysis, we have created an adapted version of the WHO's gender analysis matrix, looking at how sex, gender, and pregnancy status interact with risk factors and vulnerability, access and use of service, health and healthcare seeking behaviors, prevention, treatment, and management options, experiences in healthcare, and health and social outcomes and consequences. And we chose specifically to separate out pregnancy status, as it has both biological and socio-cultural components that really have important impacts on outbreak dynamics. We then applied this adapted matrix across the outbreak response areas of prevention, detection, treatment and management, and recovery. So starting with prevention, we have mapped the available evidence. We've grouped it into categories and then mapped it over this matrix from the literature to highlight the important ways that sex, gender, and pregnancy status relate to these various health dynamics. But in the interest of time, I'm just going to highlight a few illustrative examples found from the research on Zika on a couple of these. So one example of sex-mediated risk factors can be seen in the sexual transmission pathway of Zika, where research has found infectious virus in semen up to 62 days after onset, along with higher rates of male to female sexual transmission over female to male, and female to female. Although this research did not explore trans or intersex individuals, from the data we do have, we can conclude that women and others who have internal genitals and engage in sexual relations with people who have external genitals are at an increased risk of exposure to Zika through sexual transmission. If we look at access and use of prevention services in Zika research, we find that response efforts interacted with traditional gender roles in many South American communities, placing women in a double bind by expecting them to prevent pregnancy and Zika without challenging the normative gendered power dynamics that hindered them from doing so. As such, women were held responsible for preventing pregnancy, while the research among women found that enforcing condom use with a stable partner proved challenging, especially among lower socioeconomic status women. They feared endangering their relationships, which is backed by statistics showing 49% unintended pregnancy rates in many of these regions. And none of the Zika messaging about sexual transmission and pregnancy targeted men. When looking at experience in healthcare centers for Zika, one illustrative example found that healthcare providers in some locations actively did not discuss or disclose abortion options to pregnant patients after ultrasounds identified fetal abnormalities, despite the availability of those services. The matrix was also used to analyze evidence for sex, gender, and pregnancy-related considerations for detection, looking at diagnostics and surveillance. So a few examples from dengue. One example of gender diagnostic seeking behavior was research that found that in many Asian communities, there were lower incident rates of dengue in women observed. However, this is more likely to reflect the fact that women in those communities frequently seek care from traditional practitioners who do not report to the public surveillance systems. Another dengue study found that clinical manifestations of dengue may be confused with physiological changes in pregnancy, which can mask the real extent of infection and make it hard for physicians to diagnose and determine prognosis. So jumping on to looking at the matrix for treatment and management, I will use evidence from Ebola research to highlight some of the findings here. So research looking at gendered access to care during Ebola found that areas of armed conflict and heightened insecurity reduced access for women due to gender-based violence and attacks on healthcare facilities and health workers. In 2018, the general practice of excluding pregnant women from therapeutic and drug trials, which limits their options, was challenged by Ebola outbreak response when pregnant women continued to be excluded from trials despite fetal death rates of 100% at the time and WHO recommendations to include pregnant women. These practices are now changing. Finally, looking at the evidence for recovery-related dynamics, if we're looking at risk factors during recovery phase, it's important to note studies that found Ebola RNA in semen up to 284 days after onset. Further research is needed to tell the exact length of time and how likely it's still infected. Research on Ebola also found that women were more susceptible to economic loss as they're more likely to be involved in the informal work sector and impacted heavily by outbreaks and outbreak response measures. It's also been estimated that an additional 4,022 women will die annually in childbirth in Guinea, Liberia, and Sierra Leone as a result of the Ebola-related deaths and healthcare workers in these countries and subsequent disruption of availability of maternal and child health services. So those are just a few rapid little examples of the types of evidence that we have. But as you can see, the evidence varies by disease, by setting, by population, but taken together demonstrates that both sex and gender-related impacts on outbreak dynamics have important implications across all areas of outbreak response. And in general, we found that sex data is often collected during outbreaks. However, few publications disaggregate outcomes by sex or discuss gender roles, and even fewer examined the implications of any differences found. And when sex and gender are discussed and examined, the terms are frequently used interchangeably, which obscures understandings of the underlying causes and our ability to do more research looking into them. Not collecting, analyzing, or utilizing sex-disaggregated data and gender data for outbreak response results in misinformation, inappropriate and less effective responses, and increased negative health outcomes among vulnerable populations. So mounting evidence is really calling for an approach to outbreak prevention, detection, response, and recovery that includes sex and gender specificities and is appropriate to the response. So to meet this need, we aim to begin phase 2 of our participatory process of further understanding why this isn't happening on the ground this next quarter. So thank you so much for your time, and I'll pass the floor back to Simone.
Thanks, Emelie. So there's just one quick question in the chat for you, Emelie, so I'll let you respond to Lauren. What I would suggest is, because we have such a big schedule, so Ebuku, can I put you on the floor first, and then we'll go through questions at the end. I think that gives us a chance just to keep them all together.
Yeah,
if
thank
you're all
you.
set. Brilliant, thank you.
So good morning, good afternoon, good evening, everyone. Please, can I confirm that my slides are visible and my voice audible?
Absolutely.
Thank you. My name is Chukwuebuka. I'm a second-year PhD student at LSTM, even though, this offsite PhD where I'm still based in Nigeria. I'll be talking through this thought, how access and engagement with public health interventions, usually these are very expensive public health interventions, the context of a pandemic or disease control, how they are very much influenced by gender, and how in many cases we have a tendency to be quite blindsided to them. So this will be a brief outline for the presentation. And on the right, you will see the map of Nigeria, where my research is sort of very much situated. In yellow, top right is the Northeast, top left is the Northwest. Northeast has been affected severely by insurgency, and there's been a lot of displacement. So the North Central region is in the middle. So kind of the southern regions are to the bottom of the map. Southwest in gray, along the coasts of the Atlantic is south-south, and then that landlocked rainforest area in the green is the southeastern region. I come from one of the tiny villages in the hills. So talking about tuberculosis, in a global sort of scene, TB can be said to be the other pandemic, right? If you think of COVID-19 as the main one, for now, at least in our consciousness. Every year, 10 million people globally fall ill with TB. And last 2 years, in 2021, 1.6 million deaths were attributable to TB. On this slide, you can see the sort of big hitters, the countries with the highest burden. So Nigeria is one of those, the top 8 countries with the highest burden. And on the right, you can see a few things about Nigeria. So for example, in 2020, it was estimated that there were about 500,000 incident TB cases, right? So 452,000 new people fell ill with TB in our country. But at the end of the year, we were only able to diagnose and treat 135,800. So you can see the male-female disorder. So roughly, we had a 30% treatment coverage. The first implication was that 70 people were missing out on care. And that's significant if you think that the proportion who have missed out on care then serve to perpetuate transmission within households and communities. But as usual, I know it's important to know who they are so that we don't continue doing things in the same way. So from the same global TB report, this slide shows the total TB burden that is sex disaggregated and age disaggregated. On the left is South Africa, the second highest burden country in Africa, and on the right is Nigeria. So the gray bar is the total burden, the total incidence, right? These are estimates, but they are based on sort of rigorous national TB prevalence surveys. South Africa just published one 2 years ago. Nigeria did about 10 years ago in 2012. So the green bars are the men who had access to treatment, while the purple bars are the women who had access to treatment, the males and females, right? So across the ages. So if you observe from South Africa, you see that there are gaps across the sexes and across the ages, right? But then if you look on the right, on the Nigerian graph, you see that the gaps are almost scandalous. First, for children, there seems to be no sort of gender demarcation. But if you look at that actively productive age group, between 15 and like 54, you will see that the gaps in men, in other words, the men who miss out on TB care, become absolutely scandalous. And in all the age groups, the gap in men have become at least double of that in women, even bearing the background higher prevalence. And I can tell you that even though Nigeria is increasing in case finding recently, these patterns have remained intractable. So it was based on this that the research I'm involved in was conceptualized, is developing and evaluating gender-sensitive tuberculosis interventions that would be suitable for community settings in Nigeria. We called it the Destin Research. It was developed through the LIGHT Consortium, which is leaving no one behind in transforming gendered pathways to health for TB. It's a 6-year FCDO grant, and it has partners in different countries. I am based in Zankli in Nigeria. So we set out to answer essentially 4 questions. So the first was to explore what the issues are in terms of the gender-related factors that affect access to care. What is the problem, right? Because this is really a global phenomenon. There are only like 2 or 3 countries in the world where the TB burden is worse for females. In every other place, it's worse for men. So we do this qualitatively. We are asking, what are the gender-related factors? What are we not seeing? And this is despite the huge ton of research, as Emelie alluded to earlier, that was already in existence, but because these things can be very contextually determined, so we sought to sort of exploit in our own domain. And then thereafter, we'll do a scoping review, asking what were the gender considerations that went into the design of sort of TB interventions in the last decade. And this is in high burden countries and then low middle income countries. So high TB burden countries. So of all the TB interventions, was there any gender consideration in the design of it? And then armed with findings from objective 1 and 2, we will then sit down together with stakeholders and sort of co-create what we consider to be a gender transformative TB intervention that will be bespoke for our context, suitable for Nigerian communities. And the last bit of the PhD is to take these findings to the field. So our qualitative research was a bit tripartite in nature. We had in-depth interviews with men and women in communities. These are men who had access to TB services. So we start from the service registers of the health facilities and then snowball into the communities in a sense. Do you know anybody in your community that is coughing but has not come to hospital? So we snowball to people that both had access to care and didn't have access to care. And we try and explore the factors as they relate to gender. We also did focus group discussions amongst men in their workplaces. So sometimes these are informal workplaces. We had an FGD amongst Keke Napep drivers. And Keke Napep is a tricycle, is the commercial tricycle. It's quite popular for inner city transport in Nigeria. A motopark driver with handymen, that stand waiting for people to hire them with shovels, sort of men in informal work, and also men in formal work. We also had exclusive FGDs for women in their communities. And then, interestingly, we had key informant interviews with sort of TB program managers at state level, national level. So this was just to get a rich mix of what the real issues are, and then where the tensions are and possible areas of misunderstanding. And our findings were quite interesting. So first, to the left, we found a clear sort of gender pattern in terms of illness experience. It did seem from our research that tuberculosis achieved a level of corporeal dominance, in a sense, over female bodies than it managed to achieve in male bodies. So the women would talk about, a woman told us that she was looking like stockfish. Another one said, I don't know if you're familiar with stockfish, it's dried fish that looks really shriveled. And then another one talked about that she weighed only 35 kg and that she looked like a ghost of herself. So it was described as this domineering experience over their bodies. They embodied the illness a bit differently. And an illness experience had influence in triggers to seek care. But not only that, in experiences of stigma. The men experienced severe symptoms like coughing out of blood and tiredness, but we interviewed like a carpenter who managed to be going to his carpentry workshop and intermittently cough out blood. So they managed to make TB, in a sense, a side attraction whilst they tried to sort of soldier on, if you get what I mean. Then secondly, there was a clear gender pattern in access to information. It was clear to us that men and women access information differently. But in this information issue, there was a difference between what the program through our KII saw as information dissemination versus what the community. So for example, the TB program officers will talk about, look, we've trained radio and TV media operators, we've trained social media influencers, we conducted training for NOA, for say on TB and how they should spread the messaging for TB. And whilst the community people rated highly what they heard in their mosques, in their churches, what they heard from Keke Napep drivers, what they heard in their local communities. In fact, one man told us pump and play that, doctor, whatever he hears on radio, he takes it as government propaganda. In other words, that government is making them to, wants to make them to behave in a certain way. So there was that misunderstanding, that gap in what the program saw as IEC BCC versus what the community actually rated. And then there were gender variations in retention and care. In other words, in the resources needed to retain a beneficiary or the people we serve to retain a person with TB in care. You know, the men may need more support in terms of calls and text, but it's not all the healthcare workers that have these resources to even detect this. And then the men required more a bit to be involved in decisions around adherence. So there was need for continuous counseling pre, intra, and post-treatment. Then there were issues around health system capacity to render actually gender-sensitive care. And we found that gender frequently intersected with single parenthood, with migrant workers status, and with poverty. And then we found, interestingly, that what we usually call delay in seeking care, you know, in TB and other disease control, we talk about delay in seeking care. It was really not that the people delayed, you know, in seeking care. It was just like accumulated episodes of failed sort of trial and error in attempts to seek care. They went to places when they were ill. Perhaps the places they went to were places where our services did not exist. So on the right is a quote from a Keke Napep driver. He told us that almost 80% of all the Keke drivers are not the owners of their tricycles. So they all got it on hire purchase, and the agreement was that within their first year of use, they would pay back twice the market value of the Keke. This is through daily remittances. And they asked us pointedly that if we were the owners and they told us, look, I didn't make any money today because I went to hospital to treat cough or to investigate cough, we would quickly seize the Keke from them, which was the agreement they signed initially. So these unsavory sort of informal labor conditions put pressure on men also in accessing care. And then from our scoping review, we did a scoping review, as I said earlier, to look at TB interventions in the past decade. What was the gender considerations put into their design? And we found that, quite frankly, most TB interventions were gender blind. We designed the DOT strategy, the Stop TB strategy, just somehow assuming that men and women faced the same challenges in accessing care. So a lot of them were gender blind. Very few were gender sensitive and gender specific, but not, in fact, one or two only attempted to become gender transformative. In other words, now changing that sort of culture, that social gendered expectation of men and women. For example, whenever TB strikes the household, most of the caring will fall on the women. And many times you find households where 2 men are down with TB and maybe a child, and all of them are to be cared for by the mother of the home. And when you find them not seeking care, they're just trying to recuperate from all the money they've spent to all the sort of not care-seeking attempts they've made in the past. So we found that the interventions we put in place didn't take into account the gender-specific barriers to care that men and women were facing. And then I think this was important because the WHO Gender Responsive Assessment Scale, this tool is available online, and there's a lot of literature around this as well. So the question is, what of COVID-19 interventions? Were they also gender sensitive, gender driven, or gender blind in effect? Because sometimes a lot of resources will go to waste. They will achieve something, but they will perform suboptimally if we don't truly understand the challenges faced by each gender. And what are these challenges? Some of them are already known in literature. On the left side is well, a modified socio-ecological model. I don't know if we remember Dame Margaret Whitehead and Dahlgren. They are sort of semicircle of inequality that goes from biological factors to factors well beyond, so structural factors, to unemployment, to lack of jobs, to food insecurity. These are factors. C. Wright Mills calls them the big engines that sort of move to determine our individual lived experiences. So how do we understand the interaction between these factors in our environment and for a specific condition? So for example, there's the issue about masculinity. If you look at, so the first circle is the biological factors. The next one has to do with the individual lifestyle factors. So the risk factors, sexual behaviors, tobacco use, alcohol use, these are all risk factors for tuberculosis. And research shows that these are more uptaken by men. And there's social contacts and networks, how people mix associatively and socially in society. And then occupational exposures, the riskier jobs, the more exposing jobs, and how this intersects with gender, and then risk for disease. And then the cultural norms where women are the carers, they have to care for the children, they have to care for the men, they have to, so whenever anybody is sick, it falls on the woman. There's even a cycle, arguably outside, that has to do with things that colonialism, how healthcare has been structured from historically in these settings, and how it has then affected how men engage with those services. On the right is a picture of when we began to deliberately engage men. This is from Anambra State, when I was working with WHO as a TB officer. Then I've added this slide just as we move to close. This is COVID-19 vaccination in Nigeria. Men and women had access to this data as a WHO worker. So I just used sort of the aggregate sum of vaccine coverage. So this is in the regions of Nigeria. Circled in red are the northern regions. So the Northwest, the North Central, and the Northeast. So observe that in all the northern regions, men dominate the vaccinees. I would have presented percentages, but because I didn't have, the age stratified population eligible so that we can, the comparisons can make sense. So I've just used the raw numbers, but it's roughly 50-50 in composition, right? So, but if you look at the Northwest, the North Central, and the Northeast, men dominate the vaccinees, whilst it's the exact opposite in all the southern regions. If you think of the Southwest, where there's Lagos, the most densely populated place in the country, the men just wouldn't be bothered. The same thing in the South, there are more women vaccinated, and in the Southeast, I don't believe these things are random. So the first thing is, as Emelie said, we need to collect the data, have the data for it. And secondly, we need to understand what the factors are. What are the issues? If you think of the millions of dollars that were spent in developing these vaccines at the COVAX facility, the amounts procured by the country, and then all the logistic effort put into it, it is possible that there are mechanisms undergirding this pattern we are seeing in the data. In the North, is it possible that women have reduced access? In the South, is it possible that for some reason men are not uptaking the vaccine? And much resources, as you can see, will go to waste if we continue to implement, without, factoring in the gender-related barriers. When we discover those barriers and address them, then we have gender-sensitive and gender-specific interventions. But when we discover those barriers and actually address them and work to change the culture beneath them, then we are inching towards gender transformative. It can be argued that is even beyond the lifespan of any particular health intervention, but it's aspirational, and that is what we must aim to achieve. So I close with 2 quotes from our pilot, the pilot of our qualitative. This is a health worker, female health worker. She's a single parent and living with disability. She told me, Doc, that men will always be men. The issue is whether the health system can handle them like that. In other words, can adapt to them. And so there's this notion that men will always be men. Sometimes we call them anti-vaxxers, sometimes we call them men, trying to show masculinity, not trying to be weak, and so forth. But the next quote is from a security man in a compound not very far from mine, when we were piloting the tool. He's from the north central part of the country. His family stays there, but he's working in the southeast. So he's a migrant worker. He told me in Pidgin that my family day for Benue. Now, waiting I get from this work, them go use chop. Essentially, that what he makes from his security job is what puts food on the table, puts clothes on the backs of his children. So in a sense, men are not trying to be men, so to speak. They're just trying to feed their families. They're just trying to put food on the table, to reduce hardship for everyone associated to them. In other words, this lived experience they have come to have are shaped by factors well beyond them. And for me, I think maybe in the questions we'll explore this more, because it then behoves on us as health interventionists, health programmers, to then design programs to overcome these weaknesses. Because it's been TB, I've focused a bit on men, but we all know, as Emelie pointed out, that women face also immense challenges. And the idea is, maybe by not making the services welcoming for men, inadvertently, we put women and children at greater risk of TB just because men delay in accessing services. And I think it's at this point of conflict. Thank you very much for listening. Thank you.
Thanks, Chukwuebuka. Such a great presentation. I see applause. I'm going to push you and Emelie to respond to some of the questions in the chat, because we do have one presentation left. So I'll let Ruby play the video. And yeah, Ruby, can you share your screen? And then we'll see we'll let you guys
attempting to
in the chat.
Oh, here we go.
Hello, everyone. Thank you very much for your kind invitation. It's a pleasure to join the webinar and talk to you on monkeypox in pregnancy. The current outbreak started in May 2022 and is considered as the largest outbreak of monkeypox. And look at the numbers at the end of October last year, there were 76,000 cases of monkeypox, and of those 34 died. What is the latest data according to the WHO report? This month, there were nearly 85,000 confirmed cases. Of those, 80 died, and the cases were reported in 110 countries. Because of the scale of this outbreak, on the 23rd of July last year, the WHO declared it as public health emergency of international concern. So how does monkeypox present? Cases with typical rash and lymphadenopathy and fever and malaise. There was the concern that immunocompromised individuals could have more serious disease and have a higher case fatality rate. And we see the immunocompromised or the vulnerable individuals include pregnant women. And there was this uncertainty about the early stage of the outbreak. If a pregnant woman presents with suspected or confirmed case of monkeypox, how should we treat? So we published this article with colleagues from the Royal College of Obstetrician Gynecologists about how to diagnose, what to test for, do we isolate or not. And it's actually was a very popular article, despite the fact it was based on very limited evidence. And it was the most downloaded article in that year, more than 10,000 downloads. The evidence was very limited, with just case reports, but the evidence was concerning. There was cases of stillbirth, congenital infection, miscarriage, and preterm birth. Subsequently, we wanted to get better quality evidence, and therefore we did a systematic review of maternal and perinatal outcomes of pregnancies with pox viruses and the family. I included 29 studies, more than 1,200 pregnancies. And if you look, this is a small box, the red column, the monkeypox, the blue, and molluscum contagiosum, the green. You see that there is increased risk of maternal death, miscarriage, stillbirth, preterm birth, and risk of vertical transmission following infection with smallpox in pregnancy. Monkeypox, to some extent, similar pattern, but there were no cases of maternal death, while molluscum contagiosum was low risk, with no reported adverse outcomes. I think it's important to highlight that these estimates have wide 95% confidence intervals because of the small number of cases. So the article that I mentioned earlier, we did include this proposed algorithm for managing whether suspected or confirmed cases and with what possible treatment, vaccines, and how to monitor the behavioral well-being, and also highlighting some of the controversial areas like the mode of delivery, do we need to do section, do we need to isolate the newborn, and whether the mother can breastfeed or not. Subsequently, a number of guidelines or proposed algorithms have been published, like this article that was published in the Lancet by David Bow, and also other guidelines like by the CDC or by the Canadian guidelines. And I summarize this four documents. I'm not going to go through them because of the time, but you see the treatment options, for example, the vaccine, the birth, the monitoring, and so on. Just to highlight, in terms of the antivirals, none of them licensed in pregnancy, and highlighting that there is a number of options, and the treatment will be based on the risk versus benefits. So, is monkeypox treatment safe in pregnancy? Well, as I mentioned, none of those three antivirals licensed in pregnancy. Be careful of the bring-to-bear, because it has been reported to be teratogenic, and therefore it's better to be avoided in pregnancy. The teicoveramate, according to the CDC guideline, was considered as the first-line antiviral treatment. It has no embryotoxic or teratogenic effect according to animal studies, and therefore is likely to be paid even pregnancy if treatment is needed. The one in the middle, the teicoveramate, again is recommended only if the pregnant is severely ill because of the limited evidence. During this kind of outbreak, a number of studies or trials have been started, including the Platinum trial. It's a placebo-controlled randomized trial of teicoveramate in non-hospitalized monkeypox patients led by the team Oxford, funded by the NHR. However, sadly, pregnant breastfeeding women are excluded. What other randomized control trials of teicoveramate? There are a number of them, whether confirmed or suspected cases of monkeypox. And I put in this column in red whether pregnant women were excluded or not. And you see the platinum UK that I mentioned earlier, pregnant women were excluded. There is a Canadian platinum, and it's not really specified in exclusion criteria whether pregnant women were excluded. And the remaining studies or the trials, either pregnant women were eligible or they were not really specifically excluded. Moving on to the immunoglobulin, and immunoglobulins are antibody cocktail that's purified from blood of individuals who previously immunized with the smallpox vaccine, not licensed for use of monkeypox in pregnancy. However, other immunoglobulins have been used in the past. They tend to be safe in pregnancy, and therefore, if needed, it's likely for it to be okay to give in pregnancy. About vaccination. And there is a list of indications to give the monkeypox vaccine, including mainly whether it's contact with a case of monkeypox or a sexual partner in the last 2 weeks, multiple sexual partners in the last 2 weeks of an area where there is a high number of monkeypox cases, or healthcare professionals who come across pox viruses. And there is an indication for pre and post exposure prophylaxis. The live smallpox vaccine, ACAM 2000, that's contraindicated in pregnancy because of the risk of fetal vaccinia, which can result in adverse outcomes like including preterm birth, stillbirth, neonatal death, and adverse maternal reaction. The one that's currently available or used is the MPAPN. It's a live, non-replicating third generation vaccine against a number of orthopox viruses. And it was found to be 85% effective in against monkeypox. And therefore, to summarize, we summarize that in this article in Mass Global Health, where currently no vaccine is approved for use in pregnancy against monkeypox, the MPPN is likely there's no theoretical reason for concern. It's non-replicating. Animal studies did not report adverse fetal effects. There were data available for its use in less than 300 pregnant women, and there were no evidence of excess adverse outcomes. Very little evidence on whether it's processed in the breast milk or not, but again, because it's not replicating, it's likely to be safe. And therefore, our conclusion in this article is that avoid it if it's not needed, and if there's a possible benefits outweigh the potential non-risk of the vaccine, we should consider it. Studies of the vaccine that have been initiated during the current outbreak, and this is one that's sponsored or funded by the CDC, is taking place in the Democratic Republic of Congo. It's an open-label prospective cohort study recruiting healthcare professionals that are at risk of monkeypox infection, and it is evaluating immunogenicity and safety. Again, sadly, pregnant women are excluded. What about other monkeypox vaccine clinical trials that have been announced so far? This is a list of them, and 2 of them, pregnant women, were excluded. This is a red column, and 2 of them were not specified in the protocol whether pregnant women are excluded. So back again to pregnant women, what is the update during the current outbreak? We published that in the Lancet Infectious Disease at the beginning of September 2022. There were 52,000 cases of monkeypox, 10 pregnant women, 1 from the United States, 9 from Brazil. Fortunately, no cases of death, no cases of severe disease or evidence of vertical transmission. So how do you explain that compared to the case reports that I showed you earlier, where they highlighted the risk of stillbirth, miscarriage, preterm birth, and vertical transmission? Well, you could argue that the current outbreak is caused by a different strain, which is called milder form of the disease, that actually now we have, despite the fact it's not licensed, but you do have the option of giving treatment or vaccines to pregnant women. Perhaps maybe there is the possibility of underreporting from our cases in Africa, so the case reports highlighting the most severe end of the spectrum, and also the fact that the current break, there were many cases in high-income countries where maybe there's better medical care than the low-income countries where the monkeypox infection is sometimes endemic. What is the most recent our update data. So according to the WHO, there were 55 pregnant women. Again, no deaths, no admission to intensive care unit, no evidence of or vertical transmission. There's been one case report that was published in New England Journal of Medicine, where there is a suggestion of possible perinatal infection. The mother had vesicular rash 4 days after labor, and she was diagnosed, confirmed by PCR with monkeypox. Then unit on day 9 developed vesicular rash, axillary lymphadenopathy and respiratory failure. You can see this is the images. And the baby was admitted to the intensive care unit that required mechanical ventilation. The swabs were positive for monkeypox, but they were also positive for adenovirus. Baby was treated with teicoveramate and ciclovir. So despite the fact that the presentation likely to be monkeypox, it was difficult to prove that it's only monkeypox because of the fact that there was also co-infection with adenovirus. So really finally, just to highlight that there is no approved treatment or vaccines for monkeypox in pregnancy. It's unlikely that we will have a randomized controlled trial to collect data swiftly during a global outbreak. And we highlighted in a number of articles the fact that there's an urgent need for a systematic approach to the prevention and management, as well as collecting high quality data. Thank you very much for your attention. I'm going to stop and happy to take any questions.
So from Simon Lawson, did you collect any anecdotal evidence, especially about cholera in Sierra Leone? Sometimes it is seen as a punishment for adultery.
That's fascinating, Simon. That did not come up in any of the articles that that we found in our search, but we did have some interesting anecdotal evidence, but that isn't one of them. I would be really interested in seeing if you happen to have the citation to share.
I haven't got a citation. This is anecdotal, and it's just from working on cholera outbreaks. And it comes up, I mean, I'm sure there is similar stuff has come up about, you know, Ebola and so on. It's just the sort of thing that you come across when you're working in the field on Ebola. I just wondered that anybody had come up with that or started to collect it. I don't know of any papers.
No, I haven't seen any. The majority of the papers we got were on Zika, and among those, there were maybe 3 or 4 that were qualitative based and started to dig into more of those experiences and the local understandings, but not a lot in the published literature that we're looking at.
Okay.
Punishment.
Yeah.
Okay, great. And there's a nice little discussion going on in the chat about assessing semen samples from male survivors of Ebola, and I'll leave everyone to look at that in the chat. We have another question from Simon again about how do the gender disparities relate to HIV, AIDS, related to TB for Ebuka?
Yes, thank you. I've put a response, but yeah, the TB HIV co-infection rate in Nigeria it's really been dropping recently. As at last year's annual review, it was about 8%, and some states report even less. But amongst that 8%, it's more feminine. It's dominated by females. And if you think that co-infection starts to predict negative outcomes, so like deaths, and like even dropping out of care, so it's an important cohort to look at. But they were driven by a specific sort of risk factors. So thank you very much.
Great, I think, yes.
Is my
Back online. Yes.
So Asma, I see that there's a question for you as well. If there's any work to start to include more routinely include women in or pregnant women in vaccine trials.
Yes, there is, and in fact, it was triggered probably by the COVID 19 pandemic, when we realized that pregnomen obviously were not included, and therefore we had very limited evidence on the how effective the treatment or the drug trials or the vaccines. And we published a number of editorials and papers calling really for the international research community to ensure that pregnomen are included in these trials from the beginning. I haven't seen anything that's a guideline or a document to say, you know, this is something that's essential or recommended. Certainly, if you compare the vaccine trials for monkeypox that started during the current outbreak compared to the COVID vaccine trials, you would see that actually there is definitely more involvement of pregnomen, or at least they're not explicitly being excluded like as had been in the case before, including COVID vaccine trials. So I would say I think things are improving, but slowly. On a negative note, the platinum trial that I presented or showed, that's in the UK, and pregnomen were excluded. In fact, actually, I had a contact from one of the investigators to say that the initial plan, or they were hoping to include pregnomen, however, the ethics committee insisted on them excluding pregnomen. So I think it's really something that we need all the key stakeholders to come around the table and to commit to the fact that pregnomen should be included, or at least being given the opportunity to be included in the initial research studies.
Thanks. Yeah, and there has been actually quite a lot of like advocacy following Zika as well in that work, and it's been quite challenging. I know in Ebola in 2018, it was a huge issue as well in the Ebola vaccine trials. Thanks so much. We are over time, so I don't see any other questions, hands raised. A huge thanks to everyone for their talks, their presentations, their questions, the discussion in the chat. As usual, this will go on the IOA YouTube channel, so we will all be able to, watch it again and share it out. And we will follow weeks, and we have our next call on which will look at surveillance respiratory viruses, a pandemic potential. So that's in 2 weeks' time. Thanks, everyone. Have a good afternoon, evening, and day, and we'll see you in 2 weeks. Take care.
Thanks. Bye, everyone. Thanks very much.
Thanks. Goodbye.
Thanks. Goodbye.